So again, hello everyone. Today's session, we will have two stations. We'll have the post-operative round for the gynaecist, and we'll have also the practice session about the discharge summary. The next time, according to the request of most of the people on the group, they are sending me on private, they want the pre-operative round for gynaecist. So this time we'll do the post-operative round, and the next time will be the pre-operative round. So I think I have to start because we have time limit for the meeting. It will be 30 minutes. Then the next station, we will go for another session through the same link. Okay. I need some response, please, to know that I'm okay. Okay.
Yes.
So as a post-operative round for the gynaecist, you may face it as a station in the exam. So as usual, my advice, always try to know what to do to avoid failure in the station. The most important thing in the exam is to know how to avoid failure. So you will have either a borderline or pass. And if you are in this zone, most probably you will have pass. So what you need to do if you face a post-operative round for gynaecist, there are key points, 13 key points, put it in your mind. If you managed to mention these points in the station, definitely you will pass. Definitely you will pass. So what are the key points in this stage? If you are doing this round, as you are doing in your daily work in your hospital, introduce yourself at the beginning to the patient and to the staff, to the nurses and to your colleagues. So in any room, say, I will introduce myself to the patient and ask her permission to start the round. And please always go room by room, room by room, room by room in the labor ward, in the pre-operative and post-operative gynaecist. Don't take the priority here according to your view from the notes, because the examiner may give you an information that will change your mind and change your prioritization of the cases. So better go room by room. It will be better because you don't know what is the priority of each case after the information you will have. And also you will not be missed in between. After each room, when you are going to the next room, please always remember this point of safety. You will take the infection control measures when you are going from room to room. So you will use sanitizers or alcohol or whatsoever for hand cleaning. If you are going to examine one patient after another, you will follow the infection control measures. In all the patients, post-operative, and you are going to do the round, post-operative, you have to review the operative notes. So the most important point in the information gathering in this station is you will take the permission from the patient to review her notes to see what were the circumstances around the surgery and if there was any complications or anything or any specialty was called during the surgery, which will give you an idea about the complication or the course of the surgery itself. So always in the information gathering, remember to review the operative notes. It is a failure in the information gathering if you didn't mention the operative notes. When you start managing each case, it's better to start by the phrase, if the examiner will ask you, what's your diagnosis? You can say, putting in mind the possible differential diagnosis. So the treatment will depend on the differential diagnosis, which is 1 and 2 and 3, and whatsoever the differential diagnosis of the case in front of you. So don't go directly to the most probable diagnosis. Always remember that there are other differential diagnoses you have to search in between to reach the most probable diagnosis in each case. Then go according to the differential diagnosis. You will search for the missed points in the history and take in account the most important part in her history here is the recovery time, because this is post-operative patient, so you need to know how was the course of her recovery during the past few hours after the surgery. Relevant examination according to the differential diagnosis you put in mind. Also relevant investigations. By these relevant examinations and investigations, you will exclude the differential diagnosis one by one till you keep the final one, which is the most probable diagnosis. Whatever the patient mentions the thromboprophylaxis. Whatever the patient mentions the drug and the drug allergy. These are very important safety points. So whatever the scenario, that's what I'm always telling you. Whatever the scenario, drug allergy, and if the patient has any problem with the mobility or post-operative, always remember the thromboprophylaxis. Drugs like the antibiotics if needed, and the drug allergy. And if the patient is anemic from the investigation and you are going to consider blood transfusion, always remember to explore any concern from the patient regarding the blood transfusion. Involve your consultant in any complicated case, and if there is any complications, remember the 7 Ds of the clinical governance. So the 7 Ds: documentation, debriefing, incident reporting or DATIX, discharge, and the remaining. So 7 Ds for the clinical governance you have to remember in the station. I don't want to tell it all now because I will give you the chance to tell me what are the 7 Ds now during the practice. So these are the key points in this station. If you managed to remember these key points according to the case in front of you, so definitely you will pass this station. Am I clear?
Yes.
Okay. So going back to the station itself. So we have 4 cases here. I need 4 volunteers or 4 candidates. Each one will take 1 case and he will tell me how he will manage, how he will go through the differential diagnosis, what additional information or clinical relevant data he wants to know. He will identify the risks and the problem in each patient, and he will outline and justify a management plan specified for each case. And so in between, if I will have questions, I will ask. Okay? So who will start?
I can try.
Dr.
Falak, sir.
Dr. Falak. Okay, Dr. Falak, you read the scenario at the beginning, then start the first room.
Okay.
So for the sake of recording, I will write the scenario. This is a structured discussion for patient safety, communication with colleagues, communication with patient and families, information gathering, applied clinical knowledge. You are the ST5 and your team was on call for emergency last night. You are going to do the morning round in the gynecology ward with your junior ST3 colleague and the nurse in charge for the ward. The patient files are unavailable at the moment, so you will use the nurse's notes as a guide during the round. Imagine that you are doing the round as usual in your hospital, then you will meet the consultant or the examiner who will ask you some questions about the 4 patients in the ward. So you should have a situation awareness here. You are there with your junior ST3 and the nurse in the ward. There is no files, so you will take the nurse's note as a guide and do it exactly as you are doing in your hospital. Please, this point is very important. Why? Because if you will take it as an exam station, definitely you will be under stress and you will forget so many things. But take it easy, please. Take it easy. Dr. Falak, I need Dr. Falak doing the round now in her hospital. This is a patient post-operative in your department. So think as Dr. Falak, don't think as a candidate in the exam. It will be very easy and you already have the key points. You can remember one by one and tell me what you are going to do. So Dr. Falak, you have only 2 minutes for the case.
Okay.
Start, please.
Sir, I haven't read the scenario. Just 1 minute. I'll read it. Yes, sir, I'm ready.
Okay, so because this station is 10 minutes for the 4 patients, I will give you 2.5 minutes for each case. So you will have 2.5 minutes to finish the first case. Start, please.
Okay. Hello, I'm Dr. Falak. I'm the ST5 doing the post-operative ward round with my junior colleague ST3 and the nurse in charge. Thank you for giving me this opportunity to perform this post-operative ward round. So my first patient is 50 years old, Madeline White. She is day 3 post-Birch corpus suspension, and now she is having some concerns. Uh, she is not feeling well, and her suprapubic catheter shows that the urine output is a bit cloudy, and her urine detailed report has been done, which shows hematuria, proteinuria, and nitrates of +1. So in order to manage this patient safely, I would like to get some more information about this patient.
Okay, so
I
what
would
is the
like to
clinical information you want to know about this patient?
I would like to know the details of the procedure. I want to see if there were any complications during the procedure or not, and what was the indication for her corpus suspension.
Okay, so what are the risks and problems in this case?
So the first thing is her urine, her suprapubic catheter shows the urine output is cloudy. So I'm suspecting she could be having a urinary tract infection, and she's also not feeling well. So I'm suspecting a urinary tract infection for this patient.
Okay, so how you are going to manage?
I would like to know if she has any allergies or if she has any medical conditions, and I would like to review her drug chart to see what medications she already is on.
Okay, any other concerns, any other thing, anything else you want to add in this?
Yes, I would like to examine this patient. I would like to do a head-to-toe examination. I would like to go and introduce myself to the patient, talk to her, ask her how she is feeling. Has she been able to mobilize? Has she been able to eat and drink? And does she have any complaints? Does she have any pain or swelling? And then I would like to perform a per abdominal examination and per vaginal examination also.
Okay, so 2 minutes 47 seconds. By the end, Dr. Falak, anyway, you did well. You reached the most probable diagnosis, which is UTI. Okay, this is
But
the
I
most
don't think
probable.
I was,
But you
yeah,
didn't mention the differential diagnosis. What else? Okay,
uh, yeah.
remember the key points here in the case. First of
It could
all,
be sepsis also. Yeah, I should have mentioned.
okay, what else? The patient is not feeling well, and the estimated blood loss was 500 ml during the surgery. If this is an accepted amount of blood loss during Birch corpus suspension,
So it is higher. It could be hematoma, it could be sepsis, it could be urinary tract infection, it could be anemia also.
perfect. So now you started to think about the possible differential diagnosis. The patient main issue here what the patient wants. The patient wants to get the urinary catheter out. So you didn't mention the main issue for the patient here, and you didn't answer how you will manage it. Okay. Another point here, suprapubic catheter in Birch Kolbe suspension is not common. This is not the usual. So there was difficulty. There was some problem during the surgery. So you have to mention the operation notes. You didn't mention that I need to review the operative notes for this lady. Am I clear, Dr. Falak?
Yes, sir. I think I did mention that I would like to know if there were any complications, but I did not. Maybe I
You have to mention it specifically, please. Something else I want to. It's your way. I don't mind, but you spent 20 seconds for the introduction. I am Dr. Falak, one of the exam candidates, and I'm happy that you are giving me the opportunity. He's your consultant. You are not in the exam. You are discussing the post-operative cases with your consultant. So, hello, hi. I reviewed the cases and I'm ready for the discussion. Okay, simply, but you spend 20 seconds for the introduction. Let's go for the first case step by step. So here the patient is 50 years old. Day 3 post-Birch Kolbe suspension. Why the patient is staying in the hospital for 3 days post-Birch? This is too much. And the estimated blood loss is 500 ml. This is more than usual in these cases. Okay. Please, Dr. Rina, close your mic and your camera, Dr. Rina. Okay. And the suprapubic catheter is also not usual in this procedure. So these are all problems and risks in this case. So when I mentioned this, identify the risks and the problems in this case, you have to say, here the patient stayed 3 days in hospital, so long hospital stay. This is a problem and risk for developing VTE. Estimated blood loss during the surgery was 500 ml, which is more than usual. Suprapubic catheter in Birch Kolbe suspension is not a usual procedure, so this is also another risk. The patient is feeling less since yesterday, and her main concern is to remove the urinary catheter out. The pulse is a little bit high, there is low-grade fever, and there is blood in urine, there is protein and nitrates. So in this case, what additional information you need to know? Putting in mind the possible differential diagnosis, which may include urinary tract infection, internal hemorrhage, anemia after intraoperative bleeding, COVID pneumonia and post-operative atelectasis, VTE and pulmonary embolism. These are the possible differential diagnoses in this case. So you need from the history to review the operative notes, why the patient has suprapubic catheter, if there was any complications during the surgery, if there was any bladder injury or the urologist was called. I need to ask about the COVID symptoms and if the patient received the COVID vaccines. We are here in a COVID era. You are doing the exam online because this is COVID. So any patient with fever, please don't forget to mention about the COVID symptoms and the COVID vaccine. To exclude the possibility of VTE and pulmonary embolism, ask about if there is any leg pain or leg swelling. Then you need general examination, her vital signs, to exclude possibility of hematoma, any tenderness or rigidity, and you will examine the renal angle for the most probable diagnosis, which is UTI in this case. What are the investigations according to the differential diagnosis for UTI? You need urine routine or urine general and urine culture. You need renal function and urea and electrolytes. For the bleeding and anemia, you need full blood count. For the COVID pneumonia, if you are suspecting, you may need to do an X-ray. For VTE or pulmonary embolism, you will need ultrasound and Doppler and ultrasound also to exclude any intraperitoneal collection. The risks and the problems in this case, each box in the case will have some risks and problems, so please look at it. At each sentence here carefully, you will find the risk and the problem. The bleeding was 500 ml more than usual. Suprapubic catheter is not usual. Cloud urine, it indicates possibility of infection, long hospital stay, so there is risk of VTE, low grade fever, so there is risk of infection, whatever the source of infection, blood and nitrate in urine, this supports the diagnosis of infection. So how you justify and manage the case? This case is most probably UTI according to the investigation. So antibiotic and antibiotics after excluding allergy, VTE thromboprophylaxis, inform the consultant, then the plan of removal of the caster will be according to the protocol. Very important point, Dr. Falak, it reflects the situation awareness. There is no files at the time being. So don't forget to document your findings and your notes once the files are available. Is that clear? Hello, Dr. Falak.
Yes, sir. Am I audible?
Okay, so simply you can mention the differential diagnosis at the beginning, and according the differential diagnosis, you will ask about the missing points in the history, the parts that you need to examine in the patient, the investigation needed. Then you will identify the risks and the problems in each case, and then the diagnosis and the management of the most probable diagnosis. And don't forget to involve your consultant and to document your finding after the files are available. Is that clear?
Yes.
Okay, so who will take the next room?
Can I do, Dr. Sulu?
Yes, Dr. Salma. You have 2 minutes, doctors, 2.5 minutes for the second case, Dr. Salma. So start.
Hello, I'm one of the candidates today. I'm ready to answer your questions. So my second case is that patient is post laparoscopic that bilateral salpingo-oophorectomy, and she has BRCA1 gene mutation, and she's feeling tired and faint. So her vital sign is normal. Only the pulse is it is 90, respiratory rate 15. So she's risks that why she's faint. So I'll call for help first, and that means my gynae consultant and also anesthetist, that senior nurse. So all will come to help me. So first of all, I'll see her review her file, why there is any complicated operation and any bleeding. So I'll check her that any other comorbidities she has or not, to review her file. And then I'll put her in IV fluid and take her blood also to see that to rule out the cause. And I'll examine her also. She's pale looking or dehydrated or not. So very quickly I'll inform my anesthetist to liaise with the blood bank also, and cross-matching and group if it is not done before. Then I will stabilize the patient first. Then according to the cause, we'll manage her.
What are the risks and the problems in this case?
This could be that hemorrhage, internal hemorrhage. It could be due to ureteric injury. And it could be the bladder injury also. It could be infection. So mainly it is an internal hemorrhage. So we'll check her.
Anything else you want to add in this case?
Yeah, so very quickly we'll see her CBC, how much the hemoglobin level, and we'll arrange until the blood is ready. We'll put her IV fluid, and also the patient is day 2, so she's risk of venous thromboembolism. We'll check her her risk of venous thromboembolism, and we'll put her stocking, and later on maybe low molecular heparin. And when patient is after resuscitation, we'll debrief the patient also, and then try to after resuscitation, then maybe need laparotomy. So we'll inform the theater also and quickly arrange for laparotomy.
Okay. Very well done, Dr. Salma, but you spent all the time explaining only one possibility in this case. You are managing only one possibility. Remember before starting the case to say, I will follow the infection control measures. I will sterilize my hands, hand washing before going to the next case. Then in the next case, what are the risks and problems in this case? Go square by square. The patient is in room 2, her age is 37. So 37 with BSO, what is the risk and the problem here?
There is a risk that fertility issue.
And
fertility issue, and also that the ovary could be injured also. So other ovary is healthy or not, we have to check.
Now, think about the future also. 37 years and BSO. So this patient is at risk
hormonal.
Yes,
hormonal.
Yes,
the
menopausal symptoms.
So
also, just 1 second, Dr. Salma, also BRCA1 gene mutation. This is another risk. So she's at risk of
removal of risk-reducing surgery. That means,
at risk of another types of types of cancer.
Breast cancer.
Yes, another types of cancer. This patient feeling tired and faint after 2 days in the hospital, laparoscopic BSO, which is a day case surgery. So the patient stayed 2 days in the hospital after laparoscopic BSO, and now she's feeling faint and tired. All your concentration was about the patient that needs resuscitation, the patient which is hemodynamically unstable. But look at the hair vital signs here, everything is normal. Everything is normal. So all the measures you will take if the patient is hemodynamically unstable. So in this room, what are the possible causes? Maybe just a vasovagal attack and it resolved. There may be a possibility of internal hemorrhage, which is the only possibility you thought about. It may be due to dehydration. It may be due to the effect of the anesthetic medication the patient received during the surgery. It may be psychological, or it may be due to VTE and pulmonary embolism because the patient is in hospital for 2 days. So these are the possible differential diagnoses. So putting the differential diagnosis in mind, I need to know more information about this patient. I need to review her operative notes. Why she's for 2 days in the hospital, was there any problems? And ask about the COVID vaccine in patients during the COVID time. The general and abdominal examination, I have to confirm her vital signs. I have to rule out the internal hemorrhage. So what you are going to do, the investigations now, I need to do full blood count, renal function, urea and electrolytes, and ultrasound to exclude any collection. What are the risks and the problems in this case? So the long hospital stay, risk of VTE, BRCA1 mutation, and the risk of another cancers. Laparoscopy itself has complication, and the psychological issues in 37 years old patient who removed her both ovaries, which exposes her to the effect of hormonal disturbances and the need of HRT later and its complications. So what we are going to do in this case, a risk assessment for VTE and VTE thromboprophylaxis. I will inform the consultant. Then once the patient is stable, I will put a proper discharge plan after stabilization. She has to come back for the result of histopathology, breast exam, and HRT in the future. Please, again, don't forget in each case the documentation. Don't forget the documentation in each case. So I'm sure that's an easy information for all of you, but go systematic, Dr. Salma. Go systematic. Put the differential diagnosis in mind. Then I will start thinking what I need to complete by the history, by examination, by the investigations. Then the second question, what are the risks and the problems in the case? I will take box by box. I will find many risks in each case. Then the diagnosis and the treatment, it will depend on the most probable diagnosis in each case. Is that clear?
Yes, thank you. Dr. Sarur, only
And
one
of course,
question I
this
have.
patient needs breast exam and the HRT and the genetic counselor. Has to be referred to the genetic counselor later.
Yeah, can I ask you one question?
Yes, sure.
Because her one ovary only removed, isn't it? One side.
BSO.
So
Both removed, Dr. Hassan.
oh, sorry, sorry. Yes,
Laparoscopic
yes.
BSO.
Right. So
Okay.
that's why she needs HRT. Yeah.
Okay.
Yes.
So we will have 5 more minutes on this session. So who is going to take the third case? Dr. Nisreen?
Okay, can I try?
Dr. Wafa. Okay. Okay, Dr. Wafa.
Okay.
So, Dr. Wafa, you will have 2.5 minutes. Start.
After I finish room 2, I will wash my hand and with aseptic solution. Then I will go and check the patient. The patient in room 3, 65 years old, day 2, post laparotomy for debulking ovarian tumor, feeling and looks unwell, vomiting 1 hour ago, abdomen distended, 20, blood pressure is stable on 110/70, temperature 30 feverish, and the respiratory rate is high. Blood trace in urine, protein and glucose nothing. This patient, I suspect she is first there is sepsis, there is infection, there is internal hemorrhage, there is anesthetic complication. Then I will go to her history to check her notes. What is the grades of the stages of ovarian tumor she had? What is the stages of ovarian tumor she had? What is the complication that happened during the operation? I will examine her, check her abdomen, as it look distended. If there is tenderness, if there is pain, I will initiate sepsis 6 protocol. I will give her take blood culture and swabs and give antibiotic after ensuring there is no allergy, or after approving that there is no allergy. Check lactate, give her oxygen, antibiotic. Yes, I said antibiotic. Give her oxygen and IV fluid. I will check, do for her ultrasound to check what her abdomen distended. If there is bleeding inside, maybe open again for laparotomy and achieve check where is the bleeding point and doing hemostasis and ligating. Then a document in the patient note.
Okay. 2 minutes, 34 seconds. You can reduce the time, Dr. Wafa, by, you said the SPAR form, or you mentioned the brief about the patient in 45 seconds. So during this time, you can take the chance and identify the risks and the problems in the case during the SPAR form. You are going step by step, so you can do exploratory laparotomy for the bulking of ovarian tumor. This is a major surgery that takes a longer time. Patient feels and looks unwell, vomited 1 hour ago, and abdomen looks distended. Dr. Wafa, forget about the exam. You have patient post-laparotomy with vomiting and abdominal distension. What is the first thing that will come in your mind?
Yes, there is internal injury to the internal organ, ureteric, bladder.
The
I
most
forget.
common,
I prepared in my
vomiting,
mind what I forget.
abdomen distended and vomiting. What is the most important thing after major surgery?
Bowel injury.
Paralytic ileus.
Paralytic ileus, exactly. Exactly. So see, when you think that you are not in the exam, when you are thinking that Dr. Wafa, which is doing the round in the hospital, you will do the case in the proper way. But under the stress of the exam and you are thinking in the case as an exam case, you will forget it. So because we have 1 minute more in this session, I will go quickly through this case. So what are the possible differential diagnoses here? Dehydration, electrolyte imbalance, paralytic ileus, oily syndrome, bowel injury, and it may be collection and sepsis. These are the possible differential diagnoses in this case. The history, again, review the notes, ask about the COVID vaccine and the COVID symptoms. The patient fever is 38.5, and ask if there is any leg pain or swelling to exclude the possibility of DVT. If the session cut, please log in again through the same link. Then the general and abdominal examination, vital signs, the hematoma, tenderness or rigidity, and you will check for the bowel sounds. The investigation, as you exactly mentioned, as a case of sepsis, full blood count, renal liver function, coagulation screen, urea and electrolytes, urine culture, X-ray, erect and supine, CT, abdomen and pelvis, ultrasound, swabs and cultures, and serum lactate. The risks and the problems in this case, she has ovarian tumor. This debulking surgery is difficult and prolonged surgery. There is vomiting after the surgery and distended abdomen.